All right. Well, good evening, everybody. My name is Michael Awad. I'm a minimally invasive surgeon at Washington University in St. Louis. I, along with my esteemed panelists, will be your host for tonight's ABSITE webinar, part 2. I see a number of you are logging in still. We're so excited to have you here and welcome to what has been really a successful annual event that we've had for the last 7 years. There are, between the session we had in December and January, over 2,000 registrants from over 30 countries around the world. So we're really excited to have you be a part of this interactive ABSITE webinar. I do want to acknowledge the challenges that many of us are facing right now, professionally and perhaps personally, with the global pandemic and other challenges with that. So my thoughts go out to each and every one of you, and thank you for what you do for our patients and our communities. And I hope that you're well and that you're safe. In the face of that, I know a number of you will be planning to take the ABSITE in January, and we have found that this resource has been a useful one for many of you in helping to prepare. So with that, I'm going to share my screen, and we'll kind of go over a couple of ground rules, and then we'll kick off as we've got lots and lots of questions to go through. So first, I want to acknowledge the two co-sponsoring societies that have put on this webinar. One is SCORE, the Surgical Council on Resident Education, and the other is SAGES, the Society of American Gastrointestinal and Endoscopic Surgeons. Our outline for this evening, and this is Eastern Standard Time, I'll be just kicking off with an overview, and then we'll have 4 sections, each led by panelists selected based on their expertise, their excellent ABSITE performance in themselves, and their reputation as educators. Just to know about SAGES, SAGES is the society is kind of thought of as minimally invasive surgeons, but it's really imagining surgical care for a healthier world, and its mission is to innovate, educate, and to collaborate to improve patient care. And you can see the values there, including the unofficial value of fun, and it is a fun society. We would encourage you to consider being candidate members or active members in SAGES. There are several benefits, including these webinars, discounts to the annual meeting, which is a wonderful meeting. You get access to a number of educational materials, webinars, SAGES videos, surgical prep videos, and a network of over 7,000 colleagues and experts worldwide, as well as subscription to the Surgical Endoscopy Journal. There are different membership categories that we'd encourage you to consider based on your status. And also just a note about the upcoming SAGES annual meeting. It is planning to be held in person in Denver, Colorado in March. The program is shaping up to be a really wonderful program, and we hope that if you're able to, we can ask you to consider attending and hopefully seeing each other in person there. The other co-sponsor is the Surgical Council on Resident Education, or SCORE. Many of you are familiar with this, and it is a tremendous resource for residents and trainees worldwide in a number of modules. The questions you'll be seeing tonight were provided by the SCORE team, and I want to thank them for contributing that data bank of questions. Together, between the 2 ABSITE webinars, we're covering a pretty broad portion of the ABSITE content topics. So this is the distribution of questions that you'll see on the ABSITE. In December, we went over this top section of topics in the abdomen and alimentary tract. And tonight, we're going to be going over the rest in a number of topics that you see here. Together, between the 2 sections, covers nearly 3/4 of all the questions that you'll see on the ABSITE. The format for this evening will be interactive. So we will have each of the panelists read the question and the answers. We will bring up a poll within Zoom that you'll see on your screen. We'll encourage you to answer those poll questions, And then the panelists will go over the correct answer, why that is correct, and maybe some of the other questions and why it may be incorrect. We do have a lot of questions to go to, so it will be quite fast-paced. And unfortunately, while we can't take verbal questions, there will be a chat box. So if you do have any questions, please put them in the chat. We will do our best to try to look at and respond to those questions as best we can, but apologies if we can't get to all of the questions in the chat. So with that in mind, again, really excited. I want to give a special hearty thanks to our panelists who helped us to prepare and are taking out a chunk of their evenings and busy clinical and personal schedules. So thank you to all the panelists. And we're going to kick off first with Dr. Ivy Haskins from the University of Nebraska, who will be leading us in our discussion about surgical critical care and trauma. Welcome, Dr. Haskins.
Thank you. So we'll start with question 1. You are called to the cardiac ICU to evaluate a 75-year-old man intubated after angioplasty and placement of a drug-eluting stent in the LAD for ST elevation myocardial infarction. We were told that during femoral arterial access, there was some difficulty advancing the sheath. Post-procedure, the patient had a period of hypotension that responded to fluids. He is now hypotensive, requiring multiple pressors, and his EKG shows sinus tachycardia. His abdomen has become increasingly distended with ecchymoses along the abdominal wall and flank area. His urine output has decreased and his peak airway pressures have increased. What is the most likely reason for this patient's current status? A, massive myocardial infarction from acute stent thrombosis. B, cardiac tamponade secondary to stent placement. C, compartment syndrome secondary to arterial injury. D, acute gastric distension. Or E, acute mesenteric ischemia.
Thank you, Dr. Haskins. We're going to give about 20 seconds or so for folks to answer, and then we're going to bring up the correct answer, and Dr. Haskins will lead us in the discussion. All right, good. We'll go ahead and move on.
So the answer is C, compartment syndrome secondary to arterial injury. And it looks like most of you got this answer correct. So just a brief review, your buzzwords for this question stem are a distended abdomen with low urine output, elevated peak airway pressures, and a multiple vasopressor requirement, which all leads you towards the diagnosis of acute compartment syndrome. Question 2, a 26-year-old woman with a gunshot wound to the abdomen and hemodynamic instability is taken for an exploratory laparotomy. She is noted to have extensive injuries to the duodenum, common bowel duct, and liver. The right hepatic artery is noted to be transected with active bleeding and loss of tissue. How should this patient's right hepatic artery injury be managed? A, place a shunt with plans for future reconstruction. B, repair the artery with a venous interposition graft. C, mobilize the edges of the artery to attempt primary repair. D, reimplant the distal end of the right hepatic artery into the left hepatic artery to restore vascular flow to the liver. Or E, ligate the artery. So the answer is E, ligate the artery. And it looks like most of you guys got this answer correct as well. So just remember that the hepatic arteries, as long as it's not your common hepatic, have good collateral flow. And so you can ligate either one of them. If you're ligating the right hepatic artery, that does give off your cystic artery. And so you should take the gallbladder at the same time. Question 3, a 42-year-old woman is in the ICU following small bowel perforation and severe intra-abdominal sepsis. It is becoming more difficult to ventilate her. Her last arterial blood blood gas shows mixed acidosis with a pH of 7.22, PaCO2 of 52 millimeters of mercury, PaO2 of 62, and bicarb of 19, while an FiO2 of 100%. What are the best strategies for mechanical ventilation in this situation? A PaCO2 maintained less than 40 millimeters of mercury. B, lung recruitment with higher tidal volumes. C, higher positive end expiratory pressure and a tidal volume less than 8. Mandatory neuromuscular blockade. Or E, high frequency oscillatory ventilation. So the answer is C, higher positive end expiratory pressure and a tidal volume less than 8. Again, it looks like you guys are on track. So this patient is suffering from ARDS. Buzzwords or kind of ways to answer this question. When you're dealing with a patient who has ARDS, you want to do lower tidal volumes with a higher positive end expiratory pressure, which is the answer to this question. For a 60-year-old male admitted to the ICU develops chest pain, shortness of breath, and becomes increasingly diaphoretic. His heart rate on the monitor is 38 beats per minute. An EKG is obtained to evaluate his rhythm. The EKG shows a slow escape rhythm with the RR interval longer than the PP interval. What type of rhythm are these findings most consistent with? A, first degree AV block. B, type 1, second degree AV block. C, type 2, second degree AV block. Or D, third degree AV block. So the answer is D, third degree AV block. Looks like about half of you guys got that answer correct. So third degree AV block is characterized by absent conduction of atrial pulses. It's typically accompanied by slow escape rhythms. There is complete electrical dissociation of the atria from the ventricles. So your RR intervals end up being longer than your PP intervals. For this patient, the next step in the management would be transcutaneous pacing, followed by formal pacemaker placement. Question 5, you are called to the bedside for altered mental status of a 58-year-old male who is post-op day 1 from a CABG. He is cold and clammy on arrival with a temperature of 98.7, blood pressure 73/45, heart rate 160 and irregular, O2 sat of 98% on 1 liter of nasal cannula. Readings from his Swan-Ganz catheter show a cardiac index of 2, pulmonary capillary wedge pressure of 18. His EKG shows a wide, complex, irregular tachycardia without ST changes. Stat labs are in process and a radiology technician is on the way. What is the next best step in the management of this patient? A, cardioversion. B, immediate transfer to the cath lab. C, start vasopressors and broad spectrum antibiotics. D, emergent chest tube placement. Or E, transfusion of 2 units of emergent release blood. So the answer is A, cardioversion. Again, most of you guys got this correct. So this question is really asking you to distinguish between the types of shock. There's a nice chart, I think, in Pfizer, and we will display it here as well. Basically, you just need to know the differences between the types of shock and how they present. So this patient is presenting in cardiogenic shock. They have cool, clammy extremities, a low cardiac index, and an elevated pulmonary capillary wedge pressure, which means that their heart is not pumping out. And so that is consistent with cardiogenic shock. Question 6, a 34-year-old female presents as a restrained driver in a high-speed motor vehicle collision. On presentation, she is anxious with increased work of breathing. Initial vitals are blood pressure 145/92, heart rate 134, respiratory rate 38, O2 sat 90% on 6 liters of face mask. A seatbelt sign is appreciated on physical examination. The patient is intubated and subsequent chest x-ray reveals abdominal viscera seen in the left chest. What is the most appropriate operative technique for repair of the suspected injury? A, left thoracotomy, primary repair of the diaphragm with single layer, non-absorbable suture. B, left thoracotomy, primary repair of the diaphragm with single layer absorbable suture. C, exploratory laparotomy, primary repair of diaphragm with single layer non-absorbable suture. Or D, exploratory laparotomy, primary repair of diaphragm with single layer absorbable suture. The answer is C, exploratory laparotomy, primary repair of the diaphragm with single layer non-absorbable suture. So you always want to approach a patient like this through the abdomen, number one, so you can evaluate the viscera that was herniated through the chest. And also you can gain adequate exposure to the diaphragm for the repair of your diaphragmatic injury. For diaphragm injuries, you always want to repair them with non-absorbable suture, oftentimes in a mattress fashion. Question 7, an 18-year-old male is brought into the emergency department awake, alert, and oriented ×3. His heart rate is 80 beats per minute and his blood pressure is 130/76. He has a single stab wound measuring 3 centimeters on his left flank at the level of his second lumbar vertebrae on the posterior axillary line. The stab wound is not bleeding and obviously penetrates his flank muscle. His abdomen is soft and non-distended. Further workup of this patient should be A, NPO and observation, B, colonoscopy, C, CT scan with triple contrast, D, diagnostic laparoscopy, or E, exploratory laparotomy. The answer is C, CT scan with triple contrast, which most of you got. Remember that your part of your colon is in the retroperitoneum, and lateral stab injuries are at risk of violating the colon. And the best way to evaluate for an injury is a triple contrast CT scan. A 56-year-old male who is post-op day 7 after a right hemicolectomy has required placement of a nasogastric tube for bilious vomiting that continues to have a high output. Physical examination shows a distended abdomen and generalized weakness. Laboratory studies show moderate alkalosis. Correction of which of the following electrolyte abnormalities could have possibly avoided this situation? A, hyperphosphatemia, B, hypokalemia, C, hyperkalemia, D, hypernatremia, E, hypocalcemia. So the answer is B, hypokalemia, which most of you got. Just remember, high NG tube output is also, we'll probably touch on this in the ped section, but it's like your firstborn male baby with pyloric stenosis. So they're going to get hypokalemia, hypochloremia, metabolic acidosis. And the most important electrolytes to replace in any patient who has a bowel obstruction is potassium, magnesium, and phosphorus. So in this question, the only one that had a hypo answer was your potassium, which is a good way to look at this answer. Question 9, a 72-year-old woman with hypertension and long-standing COPD with multiple oral and inhaled medications is now in the ICU with temporary abdominal closure after small bowel resection and washout from an anastomotic bleed. She remains hypotensive. She is refractory to a fluid challenge and is requiring increasing doses of norepinephrine, epinephrine, and low-dose vasopressin. What should be considered as the next step in management? A, transfusion of packed red blood cells for a hemoglobin greater than 10. B, adrenocorticotropic hormone stimulation test. C, switching from norepi to dopamine. D, bicarbonate therapy for a pH greater than 2.5. Or E, IV hydrocortisone therapy. Your answer is E, IV hydrocortisone therapy, which almost all of you got. So keywords again for this patient, she is on steroids at home, and so she is likely suffering from adrenal insufficiency in the setting of shock. So usually giving back their steroids, usually in a higher dose and in an IV form, helps to alleviate their septic shock related to their adrenal insufficiency. A 64-year-old man with a history of alcohol dependence complicated by previous esophageal varices is brought to the emergency department for increasing confusion and lethargy over the previous 2 days. His blood pressure is 85/56, heart rate 70, and his creatinine is 3.4. On examination, the man is confused, has a large fluid wave on abdominal examination, and has made 5 cc's of urine after 3 hours in the emergency department, despite placement of a catheter and administration of 1.5 liters of normal saline. What is the appropriate next step in the management of this patient? A, TIPS, B, emergent paracentesis, C, aggressive crystalloid recession, D, midodrine and vasopressin, or E, emergent liver transplantation. Your answer is D, midodrine and vasopressin. It looks like there's a good mix of answers here from you guys. So let's talk about it a little bit. So this patient actually has hepatorenal syndrome. So his underlying issue is his liver failure, but his kidneys are not seeing any fluid. So the initial treatment for hepatorenal syndrome is you want to focus on expanding your intravascular volume that your kidneys can see. So in patients who have liver failure, they're not producing protein, so you need to give them back fluid in the form of albumin, not aggressive crystalloid resuscitation, to pull that extra fluid back into the intravascular space. And then you want to decrease their peripheral vasodilation because typically their arteries and veins have dilated because there's a component of autonomic dysfunction in hepatorenal syndrome. So you want to minimize the leaky vasculature seen with your low protein levels. And the best way to do that is with midodrine and vasopressin, which help kind of clamp down on your vasculature and improve blood flow to your kidneys to help reduce the progression of kidney failure associated with hepatorenal syndrome. Question 11, a 70-year-old woman is admitted to the surgical ICU after an 8-hour open cholecystectomy. She received 5 liters of IV fluids during the case, and her urine output has steadily decreased to 10 cc's an hour. She has never required dialysis before. She currently denies any difficulty breathing, and her abdomen is soft and minimally tender. Her bladder pressure is 13. Her baseline creatinine is 1, and a basic metabolic panel shows a sodium of 151, potassium of 5.9, chloride of 111, bicarb 21, BUN 55, and creatinine of 3. An EKG is performed with findings of peak T waves and frequent PVCs. Preoperatively, the woman had a normal EKG. Which of the following factors is an indication for urgent dialysis? A, an elevated creatinine, B, hyperkalemia, C, oliguria, D, alkalosis, or E, net fluid balance. So your answer is B, hyperkalemia. And most of you got that, which is great. So this is just memorization of your AEIOUs. And so hyperkalemia falls into your electrolyte abnormalities, and this patient also has peak T waves. A 34-year-old man involved in a motor vehicle collision presents as a trauma activation. He is protecting his airway and is hemodynamically stable. On the secondary survey, you note bruising across his chest wall and abdomen. You perform a fast examination. Where are you most likely to locate free fluid during this examination? A, pericardium using the subxiphoid window, B, pericardium using the peristernal view, C, hepatorenal space, D, perisplenic space, or E, the pelvic window. The answer is C, hepatorenal space. And it looks like half of you guys got this correct. So this is really just memorization of your most dependent area on the FAST exam, which happens to be the hepatorenal space. And maybe some of you have seen this based on your time in the trauma bay. But typically, in terms of which FAST window is most likely to be positive or more often positive, it's the hepatorenal space. A 59-year-old male sustains multiple gunshot wounds to the abdomen and is taken to the operating room. After obtaining hemostasis, you note ongoing succus in the abdomen. Which of these maneuvers will best expose the duodenum for inspection? A, the Coker maneuver, B, the Maddox maneuver, C, incising the gastrohepatic ligament, D, the Cattell-Brosh maneuver, or E, four-quadrant packing. So the answer is D, the Cattell-Brosh maneuver, and it looks like most of you put answer A, which was the Coker maneuver. So the Cattell-Brosh maneuver is basically an extension of your Coker maneuver. So your Coker maneuver is going to give you access to the proximal portion of the duodenum, but for complete exposure of your duodenum, you need to do a right medial visceral rotation, which is your Cattell-Brosh maneuver. When you're learning the differences between the Cattell-Brosh and the Maddox maneuver, so your Cattell-Brosh is your right medial visceral rotation and gives you good exposure to your IVC. The Maddox maneuver is your left medial visceral rotation and gives you better exposure to your aorta. A 35-year-old male who was a restrained driver in a motor vehicle accident and was T-boned on his side presents to the trauma bay awake with a GCS of 15. He is breathing and saturating well and complains of abdominal pain. His heart rate is 100, blood pressure 115 over 75, respiratory rate of 22, and O2 sat of 93% on 2 liters of nasal cannula. Examination shows a seatbelt sign on the chest and abdomen. CT scan of the abdomen and the pelvis with PO and IV contrast reveals a grade 2 right lobe liver laceration with a contrast blush into the peritoneal cavity. What is the appropriate initial management of this injury? A, admission to the ICU with serial physical examinations and hematocrit monitoring. B, admission to the ICU and blood transfusion to keep the hematocrit above 30. C, laparoscopic liver debridement and clipping of the bleeding vessels. D, hepatic angiography and embolization, or E, laparotomy with debridement and control of bleeding vessels. So the answer is D, hepatic angiography and embolization, which most of you got. A good kind of way to approach this question is really what is the most plausible answer. So some of these answer stems give you irrational settings. So obviously, you know, your hemoglobin threshold is typically 7, which would convert to a hematocrit of 21, not 30. And typically for livers that are bleeding, we try to not go to the operating room because we know most bleeding from the liver is not typically controlled with surgical intervention. And so just by knowing those two things, you can eliminate 3 of those 5 answer choices.
All right, and for our last question in this section.
A 42-year-old man is brought to the trauma bay after being involved in a motor vehicle crash. His blood pressure is 82/40. His heart rate is 138, despite administration of a liter of crystalloid resuscitation and 2 units of blood. A fast examination reveals fluid in the abdomen. What is the next best step in this patient's treatment? A, continue to resuscitate him in the trauma bay. B, proceed with an XLAP. C, perform DPL. D, obtain a CT scan to identify the source of the fluid. Or E, perform a resuscitative thoracotomy. Nice job, everyone, 97%. The answer is proceed with an exploratory laparoscopy. Good ending question.
Dr. Haskins, thank you very, very much for leading us through that excellent discussion and kicking us off on tonight's ABSITE webinar. Very, very expertly done. Thank you so much.
Thank you.
I'd like to introduce our next panelist, who's Dr. Amy Rosenbluth from Stony Brook Medicine in New York. Dr. Rosenbluth is going to lead us in a discussion on breast and endocrine disease. Dr. Rosenbluth, again, welcome and really appreciate you being here.
Happy to, thank you. Okay, so a 25-year-old woman comes to your office after undergoing a CT scan for abdominal pain. A 7-centimeter adrenal mass is noted. She has lab tests including plasma renin concentration to renin activity and a low-dose dexamethasone suppression test. Results are both unremarkable. What is the next appropriate step? A, undergo an adrenalectomy given the size of the mass. B, follow up with interval CT scan at 6 months. C, order an MRI to further evaluate the mass. D, order urine metanephrines and catecholamines. Or E, take no further action. Great, so most of you got it. D, the answer is order urine metanephrines and catecholamines. There were a good amount of you who picked A, have her undergo an adrenalectomy given the size of the mass. She does need to go and undergo an adrenalectomy given the size of the mass. However, you haven't completed your workup. If it does turn out to be a pheochromocytoma, obviously there's more that needs to be done before you take the mass out. A 48-year-old man presents with an 8-centimeter heterogeneous right adrenal mass with irregular borders. Biochemical workup reveals elevation in DHEAS. Which of the following is the best approach to adrenalectomy in this patient? A, a laparoscopic transabdominal right adrenalectomy. B, a retroperitoneoscopic right adrenalectomy. C, robot-assisted transabdominal right adrenalectomy. D, open right adrenalectomy. Or E, transthoracic adrenalectomy. So the answer is D, open right adrenalectomy. Most of you got this. Just a quick test taking tip. If you look at these answers, laparoscopic, retroperitoneoscopic, and robotic assisted, those are 3 answers that are all basically saying an MIS right adrenalectomy. So probably none of those are right. So then you're down to an open right adrenalectomy. We're talking about a cancer case. So we want to make sure we're not seeding. We want to make sure that we're not getting into the capsule. So open right adrenalectomy is the answer. A 41-year-old woman presents with hypertension, central obesity, and hirsutism. Workup demonstrates elevated 24-hour urine-free cortisol. Her plasma adrenocorticotropic hormone level is less than 5. What is the next best step in this patient's workup? A, low-dose dexamethasone suppression test. B, high-dose dexamethasone suppression test. C, adrenal computed tomography or a CT scan for the adrenal. Pituitary magnetic resonance imaging. E, CT scan of the abdomen pelvis. So the answer is C, a CT scan targeted for the adrenals. So it looks like most of you actually went with A, so we'll talk about this question for just a moment. So first, we know that there's already an elevated 24-hour urine cortisol. So we already know that we're looking at a Cushing syndrome. So the biochemical workup for Cushing syndrome begins with establishing elevated levels, which we have. This can be achieved through the 24-hour urine cortisol or the dexamethasone. So then we want to look at the ACTH levels, and we notice that they're low. So we don't need to do the high-dose dexamethasone suppression test, because we now know based on these two levels that we're coming from an adrenal tumor. So the next thing you want to do is look at the adrenals with an adrenal-based CT scan, not a regular CT scan. I did also want to mention with this question for you guys, things like Cushing syndrome, Cushing disease, Addison's, these are super testable because they can give you certain levels of cortisol, certain levels of sodium, potassium, and ask you what are the most likely things you need, or things like this where they're talking about different dexamethasone suppression tests. So I think it's really helpful to sort of review those things that you don't necessarily see that often before the test, because it is so easy to write a question like this. A 48-year-old woman is referred to you for evaluation of hyperparathyroidism. She has a calcium of 10, a PTH of 78. She has a history of recent weight loss due to gastric bypass. She is not taking any vitamins or supplements. She is not on any medications. What is the next best step in management? A, order a sestamibi scan to determine if she has a single adenoma. B, start the patient on calcium and vitamin D. C, perform a subtotal parathyroidectomy. D, no need for further workup given the normal calcium level. Or E, counsel the patient on initiating a low calcium diet. The answer is B, start patient on calcium and vitamin D. Not quite everyone got this, so we'll touch on this as well. So we're looking at someone who has an elevated parathyroid level and a normal calcium. But what's also really key here, and what you should remember when doing test taking questions, is that if it's in the stem, it's important. So this patient just had a gastric bypass. She is not absorbing calcium and vitamin D the way she should be. So the other thing to know, just like the last question, how easily test takeable these are, is primary, secondary, tertiary hyperparathyroidism, knowing what they are and knowing the difference. So this is secondary hyperparathyroidism because she is not absorbing vitamin D based on her gastric bypass. So she needs to be started on calcium and vitamin D. A sestamibi scan would be for primary hyperparathyroidism and looking for a parathyroid adenoma. Question 5, a 64-year-old woman with recurrent kidney stones is diagnosed with primary hyperparathyroidism. Her pre-op calcium is 10.8, parathyroid hormone is 88. Her GFR is 110. Pre-op sestamibi scan identifies a right inferior parathyroid adenoma. This correlates with ultrasound findings. She undergoes parathyroidectomy with a focused unilateral exploration for an enlarged right inferior parathyroid gland is identified. 10 minutes after resection of this gland, her intraoperative parathyroid hormone drops from the highest pre-excision value of 101 to 58. What is the most appropriate next step? A, recheck at 20 minutes. B, evaluate the 3 remaining parathyroid glands for hyperplasia or adenomatous enlargement. C, conclude the operation. D, perform a subtotal parathyroidectomy. Or E, request frozen section analysis of the excised parathyroid gland. So this is evaluate the remaining 3 parathyroid glands. Looks like some mixed answers between A, B, and C. So the main thing to know here is that you want a 50% drop in your parathyroid hormone levels from the highest pre-excision value. So if the highest pre-excision value is 101, 58 is not quite half that value. So rechecking at 20 minutes won't help you because you haven't done anything different. So that's not the correct answer. B, you reevaluate the other glands. So you're looking for any hyperplasia or adenomatous enlargement for glands that you can remove, which would improve the value so that it is then half. And C, again, you would not conclude the operation because you're not at half. So you have a higher risk of failure of the surgery. 6, a 32-year-old woman, 24 weeks pregnant, presents with a 1.5 centimeter right thyroid mass. Ultrasound of the mass reveals a solid nodule, and FNA is consistent with papillary neoplasm. What is the most appropriate treatment for this patient? Right thyroid lobectomy during 2nd trimester, subtotal thyroidectomy during 2nd trimester, total thyroidectomy after delivery, total thyroidectomy with lymph node dissection after delivery, radioactive iodine ablation of the thyroid gland 6 weeks after delivery. The answer is C, total thyroidectomy after delivery. Looks like most people actually went with A, right thyroid lobectomy during 2nd trimester. So with thyroid cancer, you try and operate either during the 2nd trimester or after delivery. So those are the 2 things to look at. Then the other thing is clearly whether you're doing a lobectomy, a subtotal, or a total thyroid for this. Because papillary is often multicentric and it's 1.5 centimeters, the recommendation is for a total thyroidectomy. There is no total thyroidectomy option during 2nd trimester given, so that makes it less confusing as far as the answers. Then just as far as the lymph node dissection, you wouldn't really do that unless you have clinically positive nodes. And you just have to be careful with radioactive iodine in women of childbearing age, and certainly can't be given during pregnancy. A 57-year-old female presents with a palpable neck mass. After a focused history and physical, you perform a comprehensive neck ultrasound, which reveals a 2 centimeter nodule in the right lobe of the thyroid gland. The nodule is solid, wider than tall, with irregular margins, intranodular vascularity, and microcalcifications. Which of these features is most specific for a malignant process? A, solid appearance, B, irregular margins, C, intranodular vascularity, D, microcalcifications, or E, wider than tall. And the answer is D, microcalcifications. All right, so most of you did go with D, which is microcalcifications. That is the most specific. And so that is what the question is for. Thyroid nodules are extremely common, and there's lots of things that can suggest malignancy. Like we said, microcalcifications are the most specific. Things like hypoechogenicity, irregular margins, solid appearance, intranodular vascularity, taller than wide, rather than wider than tall, it's in this question, are the most specific. But again, microcalcifications of all of those are most specific. A 44-year-old woman is found to have suspicious microcalcifications on routine mammography, and stereotactic core needle biopsy reveals atypical lobular hyperplasia. This was found to be concordant and no calcifications are found on the post-biopsy mammogram. What is an acceptable management plan? Observe and repeat biopsy in 6 months, excisional biopsy, tamoxifen treatment, radiation therapy, or simple mastectomy with sentinel lymph node biopsy. The answer is C, tamoxifen treatment. So let's talk about this one a little bit as well. Most of you actually said excisional biopsy. So it's atypical lobular hyperplasia and it's concordant with the findings. And actually on the repeat mammogram, you see no more microcalcification. So you don't need to do an excisional biopsy. In fact, with atypical lobular hyperplasia, you would rarely do a surgical biopsy. You would just do your core needle. But it does increase the long-term risk of cancer 4 to 5 times that of the average woman. So it is recommended to start chemo prevention with tamoxifen. A 55-year-old postmenopausal woman had a screening mammogram that showed a new cluster of microcalcifications in the left upper outer quadrant of the breast. Her breast tissue density is noted to be minimal, with mostly fatty replacement present. Another surgeon did an open wire localized excisional biopsy. The pathology showed fibrocystic disease-associated calcifications with a foci of LCIS or lobular carcinoma in situ. There's a focus of LCIS at one margin. Physical exam is unremarkable, only for a healing incision. She has no family history of breast cancer and has never been on postmenopausal hormonal replacement. What is your recommendation? A, bilateral breast MRI. B, re-excision to clear margins. C, bilateral mastectomy. D, postoperative radiation therapy, or E, endocrine therapy. And the answer is E, endocrine therapy alone, and good job, most of you guys got this. And this sort of is the same premise as the previous answer. There's an increased risk of cancer with LCIS, so you want to put them on chemo prevention. A 54-year-old female presents to your office in consultation of a newly diagnosed right breast cancer. On recent mammogram, she's found to have a 1.7 centimeter breast mass at 10 o'clock, 5 centimeters from the nipple, where the biopsy reveals an invasive ductal carcinoma, grade 2, ER positive, PR positive, HER2 negative. Her physical exam is notable for a palpable right breast mass without any palpable cervical, supraclavicular, or infraclavicular or axillary lymphadenopathy. She's interested in breast conservation surgery. You take her to the operating room for a needle localized lumpectomy with sentinel lymph node biopsy. Final pathology reveals a 1.9 centimeter intraductal carcinoma, grade 2, no tumor on ink, with 2 of 3 sentinel lymph nodes positive. What is the next appropriate step for management? A, complete axillary lymph node dissection. B, repeat sentinel lymph node biopsy. C, no further axillary surgery is needed. D, targeted axillary dissection. E, axillary ultrasound. And the answer is C, no further axillary surgery is necessary. Most of you did get this. A couple people got A. Remember, this is the Z11 trial, so if it's less than 3 positive nodes, you're done. A 45-year-old woman has routine screening mammogram that demonstrates a 2 centimeter area of architectural distortion with faint spiculations in the lower inner quadrant of the left breast. Core needle biopsy reveals radial scar. The imaging and biopsy result are concordant. What is the most appropriate next step? A, excisional biopsy, B, mastectomy, C, repeat mammogram in 6 months, D, MRI, or E, repeat core needle biopsy. And the answer is A, excisional biopsy. Most of you did get this correct. So again, just quickly, radial scars are a group of sclerosing lesions. They can mimic malignancy on mammograms. They are associated with a moderate increased risk of breast cancer. The key step after core needle biopsy shows a radial scar is getting the definitive diagnosis. So that's why you're doing the excisional biopsy. A 29-year-old woman is 2 months postpartum and has been breastfeeding her newborn daughter. She complains of a low-grade fever associated with breast pain and erythema. An ultrasound of the affected breast reveals a 3.5 centimeter cystic mass with internal echoes. What is the next best step in management? A, incision and drainage with cessation of breastfeeding. B, interruption of breastfeeding. C, stereotactic guided biopsy. D, antibiotics and ultrasound guided drainage. Or E, diagnostic mammogram. The answer is D, antibiotics and ultrasound guided drainage. Almost all of you got this, so we won't spend time going over the answer. A 20-year-old woman presents with a 3 centimeter mobile breast mass that she says has been present for 3 to 4 years without change. It's not tender or troublesome to her, and she would prefer not to remove the lump. She is nulliparous and is taking birth control pills. Family history is positive for paternal grandmother with breast cancer at age 50. What is your recommendation? A, a diagnostic mammogram. B, MRI, C, no imaging, D, complete excision, or E, ultrasound guided core needle biopsy. The answer is E, ultrasound guided core needle biopsy. You guys were not quite as sure on this one. So A, for the people who put diagnostic mammogram, this isn't as helpful in 20-year-old breasts because they're dense. C, the no imaging. Ultrasound tends to be better for younger breasts, and you would want to get some information on it if you're going to leave the mass in place. So you want to do an ultrasound guided core needle biopsy. It is most likely a fibroadenoma, but if you're leaving the mass in place, you do want to rule out a phyllodes tumor. A 50-year-old woman presents with a 4 centimeter right breast mass without overlying skin changes and no palpable adenopathy. Core needle biopsy demonstrates low-grade malignant phyllodes tumor. She has large breasts and prefers a lumpectomy if it will be safe. What do you recommend? A, wide excision with a 1 centimeter margin. B, mastectomy. C, cryotherapy. D, sentinel node biopsy at the time of surgery. Or E, radiation after lumpectomy. The answer is A, wide excision with 1 centimeter options. Almost all of you got that, so that is correct. A 50-year-old woman has a routine screening mammogram that demonstrates a new 1 centimeter spiculated mass on the right. Ultrasound demonstrates a 1 centimeter hypoechoic mass with irregular borders and posterior acoustic shadowing. Breast Imaging Reporting and Data System, or BI-RADS-4. A core needle biopsy reveals benign breast tissue. What is the most appropriate next step? A, an MRI, B, a punch biopsy, C, routine screening in 1 year, D, repeat imaging in 6 months, or E, excisional biopsy. The answer is E, excisional biopsy. And it looks like almost all of you got this. So this is a discordant finding from your BioRads and from your mammogram. So you do want to make sure that you go in and that you are doing an excisional biopsy to rule out anything going on. A 30-year-old woman presents with a mass in the left retroareolar area. She denies discharge, nipple changes, or tenderness. Her mother had breast cancer at 58. On physical exam, there's a 1.5 centimeter mobile mass under the upper areola. No discharge can be expressed. What imaging should be ordered? A, bilateral screening mammogram, B, bilateral diagnostic mammogram, C, bilateral diagnostic mammogram and left ultrasound, D, left diagnostic mammogram, or E, left diagnostic mammogram and ultrasound. The answer is C, bilateral diagnostic mammogram and left ultrasound. We're a little bit split on this. So some of this is test taking that can help you. So this is a person with a mass. So we're not doing screenings, we're doing diagnostic. And then the other thing is these are breasts. You always want to do both sides. Just because you have a finding in one doesn't mean there's not something going on in the other breast. So you want to make sure it's bilateral. And in someone with a mass, you want to make sure it's diagnostic. And then because there is a mass, you do also want to get an ultrasound of the mass. A 35-year-old female with biopsy-proven right breast invasive ductal carcinoma involving the chest wall is seeing you in evaluation for her upcoming procedure. She's 5'5", 120 pounds, and currently has a size B cup breast. She's planned to undergo bilateral mastectomy, sentinel lymph node biopsy, radiation, followed by hormonal therapy. She's interested in being the same size after reconstruction in as quick an interval as possible. What is the best reconstructive option for this patient? A, primary closure of mastectomy sites without reconstruction. B, immediate reconstruction with silicone implants. C, immediate reconstruction with tissue expanders, serial fillings, and exchange to implants after radiation is complete. D, immediate autologous reconstruction with deep flaps. E, immediate autologous reconstruction with tram flaps. The answer is C, immediate reconstruction with tissue expanders, serial filling, and exchange to implants after radiation. It does look like most of you got this, so we won't spend too much time going over it. But remember, you don't want to put implants in immediately for contracture. Just closing the sites, again, makes it harder to reconstruct right after. And then doing flaps with radiation has higher wound complications. A 50-year-old patient presents to your office to discuss her surgical pathology after a modified radical mastectomy. Her mother had breast cancer at age 60. Her final pathology showed a poorly differentiated 3-centimeter tumor, ER/PR positive, and HER2 non-amplified with 4 of 20 lymph nodes positive for metastatic disease. Which of the following is an indication for post-mastectomy chest wall radiation in this patient? The answer is D, 4 positive lymph nodes. About 2/3 of you got it. So the consensus is that patients with 4 or more positive lymph nodes or other features characteristic of stage 3 disease should be counseled to undergo post-mastectomy radiation. The tumor receptor status does not affect radiation. Tumor size greater than 5, not 3, would be considered for radiation. And the family history does not affect radiation either. A 65-year-old Caucasian woman presents to her physician with a 1.5 centimeter firm, palpable mass in the right upper outer quadrant of the breast. There's no overlying skin changes and no axillary or supraclavicular adenopathy palpable. Diagnostic mammogram demonstrates a spiculated mass without calcifications, and an ultrasound of the mass shows a 1.2 centimeter irregular mass with posterior shadowing. Ultrasound-guided core needle biopsy is done. The most likely pathological diagnosis is A, DCIS, B, invasive lobular carcinoma, C, fibroadenoma, D, invasive ductal carcinoma, or E, invasivus mucinous carcinoma. The answer is D, invasive ductal carcinoma. Most of you did get this. So remember, this is the most common type of invasive breast cancer, 70%. DCIS is much less likely to be palpable. Invasive lobular carcinoma as well is hard to find and less likely to be palpable. Fibroadenoma obviously is going to have very regular margins, and invasive mucinous carcinoma is extremely uncommon and would have a different appearance on ultrasound.
And for our last question in this section.
A 34-year-old woman presents in her early third trimester of pregnancy with an enlarging non-tender right breast mass. There are no overlying skin changes. She has no prior history of breast cancer. Her mother had breast cancer at age 60, but there's no other family history of breast or ovarian malignancy. What is the next step in management of this mass? A, defer workup until the end of pregnancy. B, ultrasound and mammogram with fetal shielding. C, core needle biopsy without imaging guidance. D, open biopsy, or E, stereotactic biopsy. And the answer is B, ultrasound and mammogram. And it looks like pretty much all of you got that. Remember, breast cancer is unlikely in pregnancy, but it can often present at more advanced stages. You can do a mammogram, you just have to do fetal shielding. Stereotactic biopsies can be done, but it's a little difficult with her trimester and with needing to do fetal shielding. Open biopsy, just so you guys know, in late pregnancy can result in milk fistulas, so core needle biopsy would be preferred when you get there, but as usual, start with ultrasound and mammogram.
Dr. Rosenblum, thank you very much for leading us through that section. That was a tour de force, and you did very well. Thank you so much for that.
Thank you.
I'd like to welcome our next panelist. Very excited to have with us today Dr. Sarah Hennessy from the University of Texas Southwestern, minimally invasive and bariatric surgeon. Dr. Hennessy, thank you so much for being with us today, and welcome. Dr. Hennessy, if you can check your microphone, we don't hear your audio.
Can you hear me? Let's see.
There we go. We can hear you now.
Better? Okay.
Yes.
I apologize. I don't know what happened. It's been working all day with lots of Zoom meetings. All right, so a 6-year-old boy presents with right lower quadrant tenderness that initially started as peri-umbilical tenderness 12 hours ago. His white blood cell count is 12,000 and an ultrasound demonstrates a 5-millimeter appendix. CT of the abdomen could not visualize the appendix. What aspect of this presentation has the highest specificity for acute appendicitis?
And Dr. Hennessy, if you could read the responses for the audience, please.
Oh, of course. A, white blood cell count of 12,000. B, ultrasound finding. C, CT finding. D, clinical history. Okay, so the answer is D, clinical history, which most of everybody got correct. And of course, with acute appendicitis, our clinical history is the most important. This young boy presents very classically with periumbilical pain and signs and symptoms very consistent with acute appendicitis. Of course, the CT scan not visualizing the appendix does not rule out appendicitis. The white blood cell count of 12,000 is not specific. And so D, the clinical history, is the most likely answer. An obese 2-year-old girl with cystic fibrosis presents with generalized abdominal pain. Her parents think that this has been going on for the past few days, but report that their daughter has been walking with a limp for the past week. She has had a poor appetite. The girl is febrile to 39 degrees Celsius and tachycardic to 145 beats per minute with normal blood pressure. Broad spectrum antibiotics and fluid resuscitation are started in the emergency department. An ultrasound is concerning for perforated appendicitis. She is taken to the operating room for appendectomy. Which of the following factors puts this girl at higher risk for having perforated appendicitis rather than non-perforated appendicitis? A, high body mass index, B, age, C, poor appetite, D, history of cystic fibrosis, or E, gender. So the correct answer here is B, age, and I see that there's a few different answers that people have picked other than age. And so, she has acute perforated appendicitis, and this is the most common surgical intervention in children. We know that younger kids are more likely than older children to present with a perforation. That obesity is not associated with a higher risk of perforation, neither is poor appetite, and neither is a history of cystic fibrosis, nor is the child's gender. So the other options that were picked, I think maybe people were thrown off by the history of cystic fibrosis, thinking that maybe that puts them at higher risk, maybe thinking that that's a form of immunosuppression, but in this patient population, it isn't. Higher body mass index can affect our clinical exam or physical exam finding. But I think in this situation, age is the most appropriate answer. Question number 3, a 4-year-old boy presents with abdominal pain, jaundice, nausea, and vomiting. A right upper quadrant ultrasound demonstrates a cystic mass that is not part of the gallbladder in the right upper quadrant. What diagnostic test is most helpful in determining the etiology of this mass? A, CT of the abdomen and pelvis, B, MRCP, C, ERCP, D, biopsy, and E, endoscopic ultrasound. So the correct answer here is B, MRCP, which most people have gotten correct. I won't spend a lot of time on this, but the biggest concern for this child is that they have a choledochocyst. CT scan can be helpful and can help diagnose a choledochocyst, but in children, it is not the imaging modality of choice. ERCP is invasive. Obviously, biopsy in the setting of a choledochocyst is inappropriate. MRCP would get you the most likely diagnosis and the safest modality for children. Question 4, a 3-year-old boy presents to the emergency department with 24 hours of bloody bowel movements. In the ER, his heart rate is 110 beats per minute. His blood pressure is 105/70, and his temperature is 36.8. On examination, he has mild tenderness to palpation in the right lower quadrant without rebound or guarding. Abdominal ultrasound is concerning for a non-compressible tubular structure emanating from the ileum. You take him to the operating room and perform which of the following procedures? A, laparoscopic appendectomy, B, mecal diverticulectomy, C, a small bowel resection incorporating a mecal diverticulum, D, mecal diverticulectomy and appendectomy, or E, a small bowel resection incorporating a mecal diverticulum and appendectomy. The correct answer here is B, a mecal diverticulectomy. We can work through it because I see that there's variable answers. So obviously a laparoscopic appendectomy is not appropriate as a patient does not have a concern for acute appendicitis. This boy has a Meckel's diverticulum. And if you remember that Meckel's diverticulums can contain heterotopic gastric mucosa, which is why the patient is likely presenting with bloody bowel movements. In the differential diagnosis, of course, here you have appendicitis and intussusception, particularly at this age range. When you find a Meckel's diverticulum, you really want to just do a Meckel's diverticulectomy. You do not want to do an appendectomy along with it or include the small bowel in the resection. You specifically don't want to do an appendectomy because it's been shown to increase risk of complication. And there's no evidence of appendicitis. And a diverticulectomy is sufficient in this case without doing a full small bowel resection. A 2-year-old boy presents to the ER with 48 hours of lower abdominal pain, nausea, and fevers. In the ER, his heart rate is 125 beats per minute. His blood pressure is 105/70, and his temperature is 38.6. On examination, he has tenderness to palpation in the right lower quadrant with guarding. Abdominal ultrasound is concerning for a non-compressible tubular structure emanating from the terminal ileum. In the operating room, you note a dilated, inflamed appendix in addition to a 2-centimeter wide tubular structure, 20 centimeters proximal to the terminal ileum. This second structure is not inflamed. What procedure do you perform? A, appendectomy. B, appendectomy with a Meckel's diverticulectomy. Appendectomy and small bowel resection incorporating the Meckel's. An ileocecectomy or a right hemicolectomy. So the correct answer is appendectomy. So, very similar intro or body almost as the last question. But this patient, the reason they're sick and going to the operating room and what you find in the operating room is secondary to appendicitis and not the Meckel's. The Meckel's is not inflamed and not the problem that you're going to the operating room for. So you only perform an appendectomy for acute appendicitis. You leave the Meckel's alone. As we stated in the last question, there's a higher risk of complication performing an appendectomy and Meckel's diverticulectomy incidentally. A 4-year-old girl presents to your office with recurrent infections in her anterior neck associated with painful swelling and occasional purulent drainage. She has been taking clindamycin for 7 days with no improvement. On swallowing, the mass moves up and down. You diagnose her with an infected thyroglossal duct cyst and take her to the operating room. What procedure do you perform? Incision, A, incision and drainage with thyroglossal duct cyst excision and hyoid resection. Incision and drainage with the thyroglossal duct cyst excision. Thyroglossal duct cyst excision and hyoid resection, thyroglossal duct cyst excision, or E, an incision and drainage. That was a mouthful.
Well said.
So the correct answer is E, incision and drainage, and we can work through it since folks picked a couple different options. So, we know that she has an infected thyroglossal duct cyst, and she's failed antibiotic therapy, which is the first line. In this situation, you would need to go to the operating room for an IND of the abscess. So that has to be included in one of the options. So you can eliminate C and D. So you're left with A, B, or just E. In this situation, in the setting of an infected field, you do not want to perform a thyroglossal duct cyst excision. You want to treat it with an IND, treat it with antibiotics, have it closed, and then bring the patient back. Incidentally, when you perform this operation, you have to make sure that you do a hyoid resection with it, because if you don't, that they have a high risk of recurrence. Okay, completely separate or new topic. A 20-year-old woman is interested in becoming a living donor for her father who has chronic cirrhosis, secondary non-alcoholic steatohepatitis. She reports moderate alcohol consumption on social occasions. Her father is ABO-A and her blood type is O. Cross-sectional imaging reveals an estimated graft to recipient weight ratio of 0.9%. It is also noted that her remnant or total volume ratio would be approximately 20%. Which factor precludes her from candidacy for living donation? Her age, B, alcohol consumption, C, ABO mismatch, D, graft to recipient weight ratio of 0.9%, E, 20% residual liver volume. The correct answer is E, 20% residual liver volume, and most folks got this correct. Again, age does not preclude her from being a donor. She's young and would otherwise be healthy. Neither is her alcohol consumption. There is no ABO mismatch here. And really, it's a 20% residual liver volume that does not make her a candidate. And in this situation, when donors are left with less than 30% residual liver volume, they have small for size syndrome. In these situations, they are not a candidate for donation. A 50-year-old man is planning to donate a kidney to his wife who has end-stage renal disease secondary to IgA nephropathy. He has mild reflux disease, but is otherwise healthy. He is adopted and does not know if there's any family history of renal disease. All age-appropriate cancer screening tests are normal. His creatinine clearance is 105 milliliters per minute. 2 repeat urine microscopy studies demonstrate 7 to 9 red blood cells per high-powered field. He is asymptomatic. A complete urologic evaluation, including a cystoscopy and CT urogram, is unremarkable. His urine albumin excretion is less than 30 grams per day, and he has an unremarkable urinary stone profile. He is adamant that he wishes to donate his kidney. What is the most appropriate next step? A, tell the patient that he's not a candidate. B, order a MAG-3 nuclear renal scan. C, obtain an MRI of the abdomen. D, perform a renal biopsy, or E, proceed with donation. Okay, so the answer here is D, perform a renal biopsy, and we can work through it a little bit since there were a couple of different choices that people picked. So we're not going to tell him that he's not a candidate because they obviously want us to do something more. So I think that that's a pretty easy eliminate that response. A MAG3 nuclear renal scan really tells us about perfusion to the kidney, as well as whether or not there's any obstruction within the ureteral system. So this would not really be beneficial to us. An MRI of the abdomen would be really looking for any masses or any other abnormalities of the kidney, but he has already had a CT urogram. So if there was going to be something abnormal, it would have been picked up on that CT. Proceed with donation, also kind of a clue. Clearly they want us to do something, so that's probably not the right answer. We want to perform a renal biopsy to make sure that there's no evidence of glomerular disease within the kidney that would preclude him from becoming a donor. Anything greater than 3 to 5 red blood cells per high-powered field is abnormal and is evidence of hematuria and needs to be evaluated. So again, doing a renal biopsy to look at the actual renal parenchyma is the correct answer. A 65-year-old male with chronic hepatitis C cirrhosis and moderate volume ascites with a known 2-centimeter hepatocellular carcinoma in segment 6 of his liver is found to have a new 3-centimeter tumor in segment 7, seen on recent follow-up ultrasound imaging. His medical history is significant for alcohol abuse in his youth, but currently abstained in a myocardial infarction requiring percutaneous coronary stent placement 2 years ago. What is the next best step in management? A, immediate listing for liver transplant. B, cardiac workup to determine cardiopulmonary reserve for transplantation. C, triphasic CT scan of the chest, abdomen, pelvis. D, psychosocial evaluation of his alcohol abuse to determine candidacy for transplantation. Or E, transarterial chemoembolization or TACE of his tumors. The correct answer is C, triphasic CT scan of chest, abdomen, and pelvis. So we can work through this one as well. Again, I think, anytime you see something like immediate listing for liver transplant, you can kind of rule out as a correct answer, as clearly they want you to do something more. Although cardiac workup, psychosocial evaluation is very important in working somebody up for liver transplantation and are important steps, it really wants to know what the next best step in management is. And in this situation, it would be getting a triphasic CT scan of the chest, abdomen, pelvis. And that's really to look at his hepatocellular carcinoma now that he has a new tumor in segment 7 to see if there's any evidence of advanced disease, either outside of the liver or within the liver, that would preclude him from liver transplantation. So the next best step is that. A 65-year-old woman with a history of hypertension, lupus, antiphospholipid syndrome, and stage 3 chronic kidney disease underwent a left cadaveric renal transplantation 1 day ago. At sign out, you were told she initially made 1.5 liters of urine in the last 24-hour period and has a systolic blood pressure in the 140s with no other issues. At 3 a.m., the nurse pages you that the patient has developed gross hematuria. On your examination, her heart rate is 106 beats per minute. She's had a systolic blood pressure of 135 millimeters of mercury and oxygen saturation is 95%. Her urine is salmon pink and not grossly bloody. What is the next step in management? A, reassure the nurse that this is normal microscopic hematuria in a patient with a cadaveric transplant and there's no cause for concern. B, send the urine for urine analysis. C, send the urine for urine analysis and give the patient a 1 liter bolus. D, order an immediate renal duplex ultrasound, or E, proceed to the operating room for a renal explantation. Okay, great. The answer is D, order immediate renal duplex ultrasound. Just very quickly, I won't spend too much time on this, but A, this is not microscopic hematuria if the urine is salmon colored. And then E, not a good response because we're not going to take the kidney out. The patient is not having low urine output or any hemodynamic issues, so giving a 1 liter bolus is not most appropriate. The renal duplex is really to look for flow to the kidney when there is salmon colored urine or hematuria or a decrease in urine output. Then you're worried about flow to that new kidney and you want to evaluate it by ultrasound. A 50-year-old man who is recovering alcoholic with a history of liver transplantation for cirrhosis and end-stage liver disease 8 years ago presents with a 2 millimeter skin lesion on his nasal bridge. Based on the most likely malignancy, what is a recommended management for this patient? A, cryosurgery, B, excision with a 1 to 2 centimeter margin, C, surgical excision to gross negative margins, D, surgical excision with a 4 to 6 millimeter margin, or E, captocytobine. So the correct answer here is D, surgical excision with a 4 to 6 millimeter margin. To get this answer correct, you need to recognize that patients that have undergone liver transplantation or any transplantation are at higher risk for squamous cell skin cancer once they're more than 3 years out after transplantation. So if you're able to recognize that this is likely a squamous cell carcinoma, then that helps you figure out which intervention is most appropriate. Because it's likely a squamous cell, cryosurgery would not be appropriate. A 1 to 2 centimeter margin is most appropriate for melanoma, not a squamous cell. You obviously want to have for squamous cell a 4 to 6 millimeter margin to be able to do a good surgical excision. So that is the correct answer. A 40-year-old man with diabetes, previous MI, peripheral arterial disease, complains of a chronic left forefoot ulcer and surrounding discoloration. He has been previously found to have left lower extremity vessel disease on arteriography that was treated with endovascular stenting. He denies fevers, chills, or pain. His foot appears dusky, but is without erythema or tenderness. His pulse exam reveals a weaker dorsalis pedis pulse on the left foot compared to the right with symmetric femoral pulses. In addressing the left foot wound, which of the following would be the next, best step in management? A, surgical debridement. B, enzymatic debridement. C, revascularization procedure. D, debridement and split thickness skin graft. Or E, extremity elevation and compression therapy. The correct answer is C, revascularization. Just very quickly, this likely represents an arterial-based ulcer and not a venous-based ulcer. And in that situation, you really want to focus on revascularization. Enzymatic debridement and surgical debridement and elevation and compression therapy all work well for venous-based ulcers, if that's what we had here, but C is the correct answer. A 60-year-old woman presents with a chronically swollen right upper extremity. She complains of soft pitting edema that's worse in the evening. Her surgical history includes a right mastectomy and sentinel lymph node biopsy for breast cancer. She denies any associated symptoms, and her most recent breast cancer screening mammogram was a BI-RADS2. What is the next best step in management? A, immobilization of the extremity, B, elevation and compression therapy, C, anticoagulation, or D, excision of lymphatics. Excellent. Everybody got the right answer. Has that ever happened before?
I don't think so. It's the first time I've seen that.
Amazing. Okay, so this is chronic lymphedema is what this represents. Everybody got it right. Elevation, compression therapy, conservative measures. This is not a DVT, obviously not excision of lymphatics right now, and we don't want to immobilize the extremity.
And for our last question in this section.
Great. A 38-year-old paraplegic man comes to your office for an area of ulceration that has developed at the site of surgical scar over his left greater trochanter. The ulcer persists despite local wound care, debridement, and pressure offloading. He developed paraplegia due to an MVC 10 years ago, and he had a pressure wound over his left greater trochanter that was treated with a free flap 8 years ago. He has been compliant with pressure wound precautions since, and is upset that he has another ulcer in the same location since he did well for so many years. What is the next best step in management? A, antibiotics, B, surgical debridement, C, evaluation for tissue coverage with free flap, D, biopsy, or E, collagenase application. The correct answer is D, biopsy, and most people chose correctly. The concern is that this is a non-healing ulcer in the setting of a previous ulcer that was flapped. And this could be a Marjolin's ulcer, which is an aggressive squamous cell cancer. A is not the right answer because it's not infected. B, you don't really have anything to debride. They've already had a free flap in this area. And so D, biopsy of the site to evaluate for cancer before doing anything else is the correct answer since it's recurrence and it's non-healing.
Dr. Hennessy, thank you for that superb overview of that section. That was amazing, and you handled those tongue twisters very, very well. So thank you so much for that.
Thank you.
And I'd like to introduce now for our final section of the webinar tonight, esteemed colleague and friend, Dr. Vipul Kadarpal. Dr. Kadarpal is a vascular surgeon here at Washington University in St. Louis, and he'll be covering the vascular section. Welcome so much, Vipul. Thanks for being here.
Thanks, Dr. Awad. So I'll be talking about the vascular questions today, even though Sarah already covered the most important one, which was revascularize every ischemic wound. So that's probably the most important question tonight. But let's start with the vascular set. A 73-year-old man with a history of hypertension, hyperlipidemia, PVD, diabetes, CAD presents to the ED with a syncopal episode. He's found to be hypertensive with a MAP of 60. He's tachycardic to 115 beats per minute. White count is elevated at 17,000 with elevated lactate. Exam shows a large right heel ulcer that probes to bone with skin changes going up to mid-calf with necrosis of the right toe. Dorsalis pedis and PT pulses are not detectable by Doppler or by ultrasound. He gets 3 liters of crystalloid and there is no improvement in blood pressure. What is the most appropriate next step? A, CTA of right leg, B, angiogram of right leg and balloon angioplasty, C, angiogram of right leg and stenting, D, open revasc procedure of right leg, and E, below knee guillotine amputation of right leg. Oh, perfect. So everyone got this right. Essentially, this guy came in septic. He did not appropriately respond to fluids. He needs to go to the OR for source control. His revascularization or evaluation of arterial studies can wait until after the guillotine amputation. Next question, a 62-year-old male with obesity, hypertension, stage 4 CKD presents to you for a permanent dialysis access creation. He's right-handed. He has palpable bilateral upper extremity pulses. Duplex shows left cephalic vein measures 2 millimeters in the forearm and 3.5 millimeters in upper arm. And on the right side, the cephalic vein measures 2 millimeters in the forearm and 3.5 millimeters in the upper arm. The basilic vein measures 2.5 millimeters in both upper extremities. What do you consent and book the patient for? A, right upper extremity brachiocephalic AV fistula. B, right upper extremity brachiobasilic fistula. C, left radiocephalic fistula. D, left arm brachiocephalic AV fistula. And E, left arm brachiobasilic AV fistula. So essentially a right-handed man with need for dialysis access. So it's perfect. So most of you got it right. So we try to make all these arteriovenous fistulas and grafts in the non-dominant arm first. You need the pre-op cephalic vein or the vein to be larger than 2.5 to 3 millimeters. For basilic vein, we prefer it to be greater than 3.5 millimeters at the very least, because it always requires superficialization. So between the cephalic vein and basilic vein, we always prefer the cephalic vein because oftentimes it's one and done. You can make a brachiocephalic fistula and you're done. As long as it matures, they can use it for access. 63-year-old man undergoes an uncomplicated left carotid endarterectomy for high-grade asymptomatic carotid stenosis. In the PACU, he develops swelling at the neck at the incision site with stridor. What is the correct management of this complication? A, emergent IR drainage of neck hematoma. B, emergent intubation in the PACU and return to the OR for evacuation of neck hematoma. C, immediate cricothyroidotomy. D, observation, elevation of head of the bed and supplemental oxygen. E, stat CT angiogram, head and neck. Perfect, everybody got it right. So again, it's an emergent airway issue. You have to secure the airway first before you do anything else. So you all got it right. We can move on to the next one. 67-year-old woman is seen in the vascular clinic for evaluation of her carotid disease. In the last 6 months, she has had 3 TIAs with right hand weakness that resolved each time. Her cardiologist recently found her to have worsening CHF, and she's now oxygen dependent. She has multiple additional comorbidities, including hyperlipidemia, type 1 diabetes, CKD, coronary artery disease. She's taking aspirin, Plavix, and statins. No previous neck surgeries. The carotid duplex shows 70 to 99% stenosis of the left common carotid artery and 50 to 69% stenosis of the right common carotid artery. What would be the best management approach for the left carotid artery? A, observation, as operative intervention is not indicated. B, continued medical management with reevaluation of operative intervention in 6 months. C, open endarterectomy. D, nuclear stress test and subsequent open endarterectomy. Or E, stent with embolic protection. So this is a mixed bag. So essentially, this is a 67-year-old female. So even though she's young, she has progressive heart failure. That puts her at very high risk of open surgical intervention. Based on the previous studies, like CREST trials, we have found that in high-risk patients who have worsening heart failure, who have neck radiation, high distal endpoints in the neck, in symptomatic individuals, the composite endpoint, which includes MI, death, and stroke, they were identical in both the endarterectomy group and the stenting group. So this patient has prohibitively high risk factors to go to the OR for general anesthesia due to her worsening congestive heart failure. So she would be a reasonable candidate for stent with embolic protection rather than doing an open endarterectomy. Even though this question does not mention it, in this day and age, we do a lot of these interventions under local with moderate sedation from a transcervical approach with flow reversal, which is another excellent option if one was presented. A 33-year-old man is brought to the ER after falling off his bike during a race. X-ray of the right lower extremity shows a displaced closed fracture of the tibia. The man is experiencing significant pain. On exam, the right leg is swollen and passive motion is extremely painful. There is decreased sensation between the first and second toes and weak foot dorsiflexion. Handheld manometer is used to calculate absolute compartment pressure of all the compartments of the lower leg, which finding is consistent with the exam. A, more than 20 millimeters of mercury in anterior compartment. B, more than 30 millimeters of mercury in anterior compartment. C, more than 25 millimeters mercury pressure in superficial posterior compartment. D, more than 20 millimeter mercury in deep posterior compartment. Or E, more than 15 millimeter mercury pressure of deep posterior compartment. All right, so let's look at this question. So it has a lot of, it presents to you a lot of information, but essentially what they're asking you is there's decreased sensation between the first and second toes and weak foot dorsiflexion. So the compartment involved here is obviously the anterior compartment with peroneal nerve being involved, right? So by definition, any patient who has compartment syndrome has to have more than 30 millimeters of mercury pressure when you check for compartment syndrome. So in essence, they're trying to identify if you picked up on which nerve was involved and by default, which compartment was involved. And the second part of the question was, what should be the absolute pressure in that compartment to qualify for compartment syndrome? So even though compartment syndrome is generally a clinical diagnosis, if you had to put a manometric measurement to compartment syndrome definition, that would be greater than 30 millimeters of mercury. 59-year-old man with a history of hypertension, CAD, type 1 diabetes, presents 1 week after a visit to the ER for a fever of unknown origin. He reports mild headache and foot pain, but has no other concerns. His blood pressure is 165 over 96 millimeters of mercury. Heart rate is normal. Lab studies shows HbA1c of 9.3%, normal potassium and glucose of 401 milligram per deciliter, lactate 1.5 milligrams per deciliter, and white count is 9,000. On exam, you note a single 3 centimeter non-tender superficial ulcer of unknown chronicity with surrounding erythema. There is no crepitus, and bilateral dorsalis pedis pulses are palpable. Which of the following treatment regimen would have the greatest effect on the patient outcome? A, insulin plus local wound care. B, vancomycin. C, linezolid plus clindamycin. D, metoprolol plus insulin. E, revascularization. All right, perfect. It's one of those questions that we all see during ABSITEs all the time. They're not fact-based questions. You just have to pick the best worst option, essentially, in some of these cases. So let's look at these options. So essentially, this is a 59-year-old poorly controlled diabetic who showed up with fever of unknown origin and now is presenting to you for an evaluation. His white count is normal, so obviously he's non-toxic. His blood glucose is out of control. It's not been under control for over 3 months, which is reflected in his HbA1c. His ulcer is described as being superficial with some erythema around it, but it has no crepitus or signs of bad infection. His dorsalis pedis is palpable, so that kind of, they're trying to tell you that the circulation seems intact. So both option B and C, I would not pick either one of them because they're both different antibiotics. While the ulcer could be infected, why would I pick B or C? You know, if they said there's a gangrene, sure, I could think of option C because you're adding clindamycin for anaerobic coverage to linezolid, but given the fact that there are two antibiotic options, I would not pick either one of them. D makes no sense because metoprolol has not, you know, plus insulin. His blood pressure, yes, it's a little bit elevated during the visit, but it's not going to make a tremendous difference in the outcome for a diabetic foot ulcer. E, revascularization, they describe dorsalis pedis pulses as being palpable, so it's unlikely that there is significant PVD based on the stem. So I would pick insulin and local wound care because these patients do need tight glycemic control and regular routine podiatry care and good wound care to improve their wound healing and decrease the chance of limb loss. You're evaluating a 64-year-old patient in your office for leg swelling. She likes to exercise 3 times a week and regularly walks 1 to 2 miles every day. She has had significant edema of both legs for several years. Left side is slightly more swollen than the right. Her medical history is significant for depression, hyperlipidemia, and GERD. Her legs have 2+ pitting edema bilaterally, as well as hyperkeratosis of the skin. There is also edema of her feet and her toes. There is no erythema or induration. She has palpable pedal pulses, and duplex does not show any evidence of DVT. What is the most likely cause of her leg swelling? A, bilateral DVT. B, heart failure. C, bilateral venous insufficiency. D, lymphedema. And E, arterial insufficiency. All right, so let's talk about this since there's a mixed response on this one. So obviously nobody picked A because there was no DVT. Option B, heart failure, unlikely in somebody who is otherwise healthy and fit, exercises 3 times a week and walks a couple of miles a day. There's no arterial insufficiency because the pulses were palpable. So between C and D, so the stem does not mention anything about varicosities. So while bilateral venous insufficiency is possible, the stem of the question specifically mentions hyperkeratosis of the skin and involvement of feet and toes, which is pretty typical for lymphedema, unlike just venous insufficiency. Squaring of toes, involvement of dorsum of the foot are typically findings of lymphedema. So during early stages of lymphedema, while the swelling can be somewhat similar to just venous insufficiency or varicose veins, in lymphedema, typically you do not see any varicosities, which were not mentioned here. So between the two choices, given the findings of hyperkeratosis and involvement of both feet and toes, lymphedema seems to be a better fit in this particular question versus option C. 70-year-old woman with past medical history of open AAA repair presents with fever, malaise, and upper GI bleeding. A CT shows fluid and gas around the proximal aortic graft and thickening of distal duodenum, consistent with an aortoenteric fistula. After initiation of IV fluid resuscitation and antibiotics, she's taken emergently to the OR for repair. After aortic clamp control is achieved and duodenal injury is repaired, the most appropriate operative management of aortic graft is which of the following? A, repair of the defect in aortic graft with non-absorbable suture and buttressing with an omental overlay. B, partial resection of proximal portion of aortic graft and placement of interposition prosthetic graft. Option C, total excision of infected prostatic aortic graft and in situ replacement with native saphenous vein graft. Option D, total excision of infected graft and replacement with in situ reconstruction of aorta using lower extremity deep veins. E, total excision of infected prostatic graft and ligation of infrarenal aorta and bilateral iliac arteries. All right, option D. Again, a mixed response. So let's talk about one at a time. So essentially, this is an aortoenteric fistula. This is a surgical emergency. An old graft erodes into the D3 or D4 segment of duodenum, causing acute GI bleeding. The traditional answer for a scenario like that after resuscitation was extra anatomic bypass and then going into the abdomen and then removing the entire graft, oversewing the aortic stump and putting some momentum on it. There's always a concern for aortic stump blowout down the road because the integrity of the tissue is pretty poor. So, and as an alternative to that, people have started doing more and more in situ reconstructions. If there's just a aortic endograft, like a straight tube graft repair, this can be not easily repaired, but this can be repaired by harvesting femoral veins from both legs and then repairing the aorta in an inline fashion with these deep veins. The native saphenous veins are too small to be used as a conduit in these circumstances, which is why the femoral veins have to be harvested. Some of you chose partial, just repairing the aortic graft in an infected aorta. This will not work. It will fall apart right away and it will bleed out. Same is the case with partial resection of the aortic graft. Just ligating the infected graft or ligating the aorta and iliac artery is not adequate unless you are revascularizing in an extra anatomic fashion ahead of time. A 20-year-old cross-country runner presents with pain and coolness in her left leg while running. Resting ABI is normal. She has palpable pulses at rest. With plantar flexion, her dorsalis pedis and posterior tibial pulses disappear. MRA in neutral position shows medial displacement of the normal popliteal artery. What is the best treatment? A, exercise therapy. B, antiplatelet and anticoagulation. C, angioplasty and stenting. D, myotomy. And E, surgical bypass. I think there's a question in the chat about saphenous vein graft. So saphenous vein grafts are generally too small for aortic repair, yes. So the right answer in this case is myotomy. This is popliteal entrapment syndrome. This is likely type 1 or type 2. Oftentimes, young individuals who have issues with leg pain, where typically on physical exam, as you plantar flex their foot, they lose their pulses. They're best investigated by doing MR angiography with provocative maneuvers with dorsiflexion and plantar flexion of the foot to see what the alignment of popliteal artery looks like compared to the muscle. In this particular scenario, exercise is not going to help because this is not an atherosclerosis related process where you encourage exercise to build collaterals. This is essentially an anomalous band of gastroc that is compressing the popliteal artery with motion. Antiplatelet therapy, again, will not help with this. Angioplasty and stenting is actually contraindicated in this scenario because if you put a stent across a popliteal artery that is getting extrinsically pinched with these muscular bands, the stents will fail and you will have limb ischemia. Surgical bypasses can be considered on a case-by-case basis, but essentially the first part of the procedure is doing a myotomy through a posterior approach, removing these bands which are compressing the popliteal artery, and then evaluating the artery. If it's abnormal, if this has been going on for a long time, sometimes we do have to do patch angioplasty or bypasses. A 33-year-old male with history of multiple illicit drug use and recent cardiac cath 4 months ago presents to the ED with spiking fever, chills, erythema, and severe right groin pain. On physical exam, there is a tender indurated pulsatile mass in the right groin. His blood pressure is 110/60, heart rate is 103, white count is elevated with the left shift. CTA shows 0.8 centimeter pseudoaneurysm of the common femoral artery with perivascular fluid collection. What definitive management would you recommend? A, echo to rule out endocarditis. B, IV fluid and broad spectrum antibiotics. C, excision and ligation of pseudoaneurysm. D, ultrasound of right groin and right upper thigh. E, endovascular repair and stent. All right, so most of you got it right. So this is an infected, this is a mycotic pseudoaneurysm, most likely from direct injection of a dirty needle into the artery by accident by a drug abuser. These cases always require operative debridement of all surrounding tissue, and oftentimes also debridement of the vessel involved with reconstruction. Echo, in this case, it's not relevant, although a lot of mycotic aneurysms are related to infective endocarditis, where patients can seed different vessels by throwing emboli of these infected from these infected valves. But in this case, this is a drug abuser who most likely accidentally injected his artery with a dirty needle, requiring surgical debridement. Stenting across infected pseudoaneurysms is not ideal and reserved only in really terrible cases. So that's not the best answer in this case. And CT was already performed, so ultrasound is not warranted. A 23-year-old female Olympic swimmer presents to the ER with acute left arm swelling, erythema, and pain. Symptoms began after swim practice about 3 hours ago. She has a palpable radial and ulnar pulses, and motor and sensory functions are intact. Duplex shows acute DVT involving entire subclavian and axillary vein on the left. What is the next best management? What is the next step in management? A, arm elevation, initiation of oral anticoagulation and discharge. B, catheter-directed thrombolysis, followed by left rib resection after resolution of thrombus burden. C, left first rib resection. D, catheter-directed thrombolysis, followed by angioplasty and stenting of compressed subclavian vein. So the answer is B. Most of you got it right. This is an important question on the test, thoracic outlet syndrome. So obviously, since the patient has acute DVT with significant arm swelling, the first order of business is to remove that clot, whether that be through thrombolysis or mechanical thrombectomy percutaneously, and then plan a first rib resection, which is causing extrinsic compression on the vein to prevent recurrence. Angioplasty and stenting is never the right answer for these patients without decompression, because the stent won't be able to expand against a rib and it will fail right away. Overall, thoracic outlet is very heavily tested on the exam. There's almost always at least one question about either the anatomy or the presentation from a thoracic outlet syndrome standpoint.
And for our last question of the evening.
65-year-old woman with a history of varicose veins in bilateral lower extremities presents with acute onset pain in her right medial thigh that extends into her leg. She has a palpable cord on the medial thigh and leg with surrounding erythema that is very tender to palpation. A duplex ultrasound exam of her venous system shows extensive thrombus within her entire GSV, but is located more than 2 centimeters away from saphenofemoral junction. What is the next step in management? A, start aspirin. B, admit the patient and start IV heparin. And C, prescribe warm compressors and NSAIDs. D, perform surgical excision of right GSV. E, start IV antibiotics. So in the chat, the spiral venous grafts are mostly used for reconstructions of vessels like external iliac arteries and more often common femoral arteries. Spiral grafts of that size involving that length of aorta are generally not feasible with the greater saphenous vein.
Okay, and we have the correct answer posted.
Oh, perfect. So essentially, this is a patient who presents with superficial thrombophlebitis. The clot in the greater saphenous vein is greater than 2 centimeters away from the saphenofemoral junction. So the chances of progression into the common femoral vein causing a DVT is low. So this patient would be best served with medical management that involves warm compressors and NSAIDs. This person does not need an aspirin and does not need anticoagulation. If the clot burden extends to the common femoral vein or inside the common femoral vein, those patients can be considered for antiplatelet therapy or anticoagulation on a case-by-case basis, depending on their situation. There's no role for IV antibiotics because it's not infected.
All right.
What?
Excellent. Thank you for closing us out with that amazing review of Vascular. Again, a real tour de force. I want to ask our hosts to please post the survey in the chat while we make a couple of concluding remarks here. So coming up in your chat will be a link to a survey that we'll ask you to please complete. We take all of the feedback very, very seriously, and we make updates every year based on your feedback. This webinar, as was part 1, will be recorded or is recorded and will be posted on the SAGES website in the next few days for your review. Part 1 is already there, and you can go ahead and take a look at it if you missed part 1. I do want to give, again, a very, very hearty thanks to all of our panelists who provided an amazing review for us today and took out their time out of their busy schedules. We want to also wish you all good luck on the ABSITE. I hope to see you at SAGES in Denver, Colorado in March, an amazing meeting that I hope you get to attend in person. But most importantly, we're all thinking of each other and supporting each other during these times of the pandemic. Please take care and be safe. Thank you all. Have a good evening and good night.